Good morning or good afternoon. My name is Monica Pica, and I'm with Sachs Healthcare Communications. Before I introduce our moderator, Lauren Skinner, and our speaker, Barbara McLean, I would like to review a few housekeeping details. Today's webinar is being recorded. You may ask a question at any time during the presentation by typing your question into the Q&A box located on the right side of your screen and pressing enter. Our speakers will try to answer as many questions at the end of the presentation as time allows. If you experience technical difficulties, please use the Tech Support tab, also located on the right-hand side of your screen. If you have trouble seeing the slides at any time during the presentation, please press F5 to refresh your screen if you're using a PC, or Command R if you're using a Mac. Please make sure you are not behind a firewall, as this will prevent you from viewing the presentation. I'd like to introduce again our moderator, Lauren Skinner. Lauren has worked in orthopedics, neuro ICU, and as a transplant coordinator before finding her home at Grady Health Systems. Lauren currently is employed as a critical care nurse in the surgical trauma ICU at the Burn Center. She is actively involved in several programs at Grady, including the training of new graduate nurses and as a lead in the hazardous infectious disease team. She is currently pursuing her acute care nurse practitioner degree with a specialty in forensic nursing. Welcome.
Thank you so much for that lovely introduction. The title of our webinar today is Lifting the Burden and Enhancing Our Care. Speaking on this topic is my friend Barbara McLean. Barbara is a critical care program specialist at Grady Systems for emergency services as well as the cardiovascular service line. She's a member of many professional organizations, including the American Association of Critical Care Nurses and the Society of Critical Care Medicine. She's received multiple awards for clinical practice, education from Grady Health System, as well as the state of Georgia, the AACN, and the SCCM. She's written 24 chapters, 30 articles, and is a regular reviewer for the Critical Care Medicine Journal, Intensive Care Medicine, and the New England Journal of Medicine. She is a world-renowned speaker, providing over 3,800 programs on hemodynamics, sepsis, and COVID-19, as well as clinical monitoring. She is the clinical advisor for the Sepsis Alliance and the Sepsis Coordinator Network Advisory. Barbara has disclosed no relevant financial disclosures in reference to this presentation. All right, and this activity has been approved for continuing education. Respiratory therapists and nurses will get a link after the presentation in order to collect their CE information. We'd like to thank Philips for providing educational for support for this educational activity. So now I would like to turn it over to my educator, my mentor, and also my friend, Barbara McLean.
Thank you so much, Lauren. I really appreciate your kind introduction. Lauren and I have known each other for quite a few years. We went to Africa on a mission together. We're on the hazardous disease team together, and she is a leader in clinical practice here at Grady Health Systems. As some of you may know, Grady is funded for 998 beds. We have 140 adult critical care beds. It's a massive project to be here at Grady, and those of us who are here, we love our mission. We're so thrilled to be able to help our patients. And I hope today, in sharing with you some of the methods of evolving our technology and utilizing technological support at the bedside, we can understand how this can lift our burdens and enhance our care. I do want to apologize. It does seem to be a little bit slow in terms of the interface, so please forgive me if it's somewhat slow as we move forward. So thank you so much. So today's objectives are really to discuss some of the challenges that present themselves in medical, surgical, step down, ICU areas, and to really help us to identify barriers that we might perceive or that may be actually truly resistant barriers to technological support, and also to the use of predictive algorithms and machine-based learning. Now, we're going to relate that use of the technology to talk about how that can impact our patient safety and assist us in improving outcomes, which is, of course, what we're all about and what our desire is always to improve patient outcomes and to actually relieve some of our burden at the bedsides so that we can also improve our care. So I want to start off with some definitions of safe staffing. And these definitions are gathered from the WHO, the US Health Census Department, also from the AACN and the Society of Critical Care Medicine, as well as many publications that are currently in publication and capability for you to visualize at this time. So you'll see at the end, I have some reference lists that you're welcome to look at and actually pull from to have some understanding of what this perspective is. But we know that the recommended staffing ratio in teaching hospitals, which are large and abundant and have high acuity, similar to my institution, is to have 1 to 3 on a step down area, and in a general hospital on a medical surgical area, 1 to 5. And that should also include a senior nurse or a nurse leader who acts as a resource nurse. Well, by the way, I would say this is an unlikely event, especially post-pandemic. We're all struggling with our staffing ratios, but safe staffing ratios, one of the main contributors of whether or not a facility is successful and whether or not feel that their value is enhanced in the care of patients, where they end their day feeling like they have done what was necessary for their patients. Now, one of the most important things, and we all know statistics speak really highly, is that patient mortality rates reduce by 7% if we have a safe staffing ratio. And as many of you know, there's been a lot of discussion about safe staffing ratios, again, particularly post-pandemic, and movement to actually legislate safe staffing ratios. But what's also really important to appreciate is that when we have better staffing, so 1 to 3 in a teaching hospital on a med surg floor, 1 to 5 in a general hospital on a med surg floor, that this actually over time saves our facilities significant amounts of money. And by the way, no big surprise to us, it really reduces significantly nurse turnover rates. So that's incredibly important when we're thinking about that. So now I'm going to look at basically, I've gathered this from New York State, from Illinois State, and from the state of California, looking at safe staffing ratios. And again, our focus today is primarily medical surgical, but if you take a look at this, med surg 1 to 4, emergency room 1 to 3, intensive care 1 to 1, when I look at this, I would say we haven't seen that since 20 years ago, that our staffing ratios do not necessarily meet this criteria, which is what is considered to be an effective way of staffing to provide the best possible care for our patients. So as we move towards those safer staffing ratios, as we move towards the ability to actually legislate this, it really does require that we have adequate resources and supplies. In my own institution, I would say my perspective would be we're incredibly resource rich. And that's because I travel to other countries and see issues of depletion that are much greater than us. But oftentimes our nurses are struggling to find equipment and supplies, and the equipment is broken or it's gone to another unit. And that's really important and an important factor in safe staffing ratios, that you have individuals who are assigned to manage equipment and make sure that medication is right in your Pyxis or on your medication cart in your area. And also the idea of teamwork. When nurses work together collaboratively with other healthcare team members, physicians, pharmacists, therapists, patient care technicians, to improve outcomes and to actually discuss and reduce patient errors without fear of reprisal. And in that way, we can really increase our patient satisfaction. And this, of course, creates what we call a healthy work environment. We all appreciate that the burden that we face today of poor staffing ratios, increasing time and documentation, and that frequently we have events that actually, were we able to spend more time with our patients and were we able to predict and evaluate patients who may be decompensating and to be able to do that earlier, it would significantly reduce our sentinel events and improve our perspective of our value at the bedside. So these are really important aspects when we're talking about staffing ratios and what safe staffing ratios mean. So now I'm going to introduce Monica back. She's going to talk about the poll question. We're going to take a short poll and then we're going to move ahead. Thank you.
Thank you so much. We're going to ask this question that you see now popping up on the right-hand side of your screen. Please make sure you're not in full screen mode in order to participate. We're going to ask this question before and after the body of the question, the body of the presentation, so that we can, get your feedback, get your opinions, and see if anything changes your mind afterwards. Now, this will be anonymous, so just make sure you can go ahead and answer yes or no to, can technology impact my patient and supplement my care, but not replace me? It's a simple yes or no. So we'll go ahead and put that up. Please go ahead and answer, and we certainly appreciate your participation and your feedback. And I will turn it back to Barbara. Thank you.
Very good. I'm going to move ahead, but we're going to keep the poll open for about 45 seconds, and then we're going to see what your answers are. Now, I want to remind you about what our burden is. And I think it's really important for us to discuss that, to hear each other, to have a pathway of true transparency, to really discuss the burdens for us that are occurring at the bedside. And we're really grateful to organizations like AACN, like the Society of Critical Care Medicine, even the JCH are bringing to the forefront the burdens of not having safe staffing. So I want to look at some statistics, and then I really want to look at the value and the possibilities for us in the future in terms of moving ahead. So very important when we're thinking about our burden and remembering what is unsafe staffing. So this is defined as an intentional practice in which hospital management does not schedule appropriate number of registered nurses, and not just the amount of nurses, but also nurses with the appropriate experience who can care safely for patients in a specialized unit driven by desire, uh, not the nurse, but the hospital, driven by desire to increase hospital profits. So you may or may not face this burden yourself. I would say the most important part of this burden is that we are all perceived to be able to apply the same care. I want to be sure you appreciate, if you put me on a med surg floor, I completely fail. I'm an ICU nurse. I have an ICU mentality. I spend hours with one patient and all the rest of my patients might be floundering. So I think it's really important for us to recognize our specialization doesn't make any one of us any better than the others, but it does actually tunnel the way in which we care for patients and organize our time and perform our duties. We are not all interchangeable, but sometimes we feel like our hospital leadership thinks that we are. And we also really appreciate that there may not be a robust pool of staffing, PRN nurses, nurses who are willing to work overtime, who can flex up or down as our patient loads increase. And also, very importantly, to remind ourselves that when we have individuals who have signed on to work, those nurses may get called off because the acuity has dropped, which makes them less likely to sign on. It disincentivizes the way in which nurses choose to work. Okay, so now we think about how that makes our working conditions, where we have concerns about what our practice is, what our colleagues' capabilities are. Do we need to be, of course, we're always supportive of our colleagues, but do we need to have a high degree of oversight, which means less oversight for our patients, and going forward and actually evaluating what's occurring for our patients? So I think these points are so incredibly important. And as we look at these statistically, it's beautiful study published in the British Medical Journal from a variety of Illinois hospitals, 87 acute care hospitals in the state of Illinois. Again, looking at those staffing ratios, which are what are recommended, and looking at the of nurses in terms of the number of patients that are assigned to them during their last shift. Did that actually exceed the number of patients that they could care for? So what you're seeing here is the actual assignment, 4 or fewer, 5, 6 or more, and nurses' perceptions about whether or not that exceeded their capability. Now, a lot of this is what drives staffing ratios. So you can see 4 or fewer, this is on med-surg units in an acute care hospital, 82% feel like, okay, it's almost 83%, okay, this does not exceed the safe staffing ratio. And when you get down to 6 or more, which I think is much more common on med-surg units, 5 or 6 or more, probably not more than 6, you see that the nurses feel that that significantly exceeds their capability to provide appropriate care. Now, of course, this was an anonymized survey. No one wanted to have anyone be punished, just wanted to recognize what nurses' subjective views were about how many patients they were caring for and how safe they were, or how they felt that it exceeded their capability. Not because they're not excellent nurses, not because they're not experienced, not because they don't want to do the right job, but it's just too many patients to actually care for. So this was really important. Now, this is followed up and very, very significant. And again, I just want to highlight these numbers. So with 5 or more patients, 58% felt that it exceeded their capability. 6 or more, 67% felt like it exceeded their capability. This is followed up by another survey from this same analysis, which actually talked about mortality and length of stay. So when nurses had less than 5 patients, 30-day mortality was around 6%, and length of stay was around 4 days. Now, obviously, there's a standard deviation that, of course, is affected by the acuity of the patient. But trying to actually limit the effect of those variables, you can see here with a nurse to patient ratio of 5 to 6 patients, and the number of patients were 44, 6.1 30-day all-cause mortality, so that was an increase, and length of stay, 4.1 days, also an increase, and these are all statistically significant. And then greater than 6, this is where you see the biggest, not such a big change in percent, but when we're looking at numbers, that means that that same percent meant a much bigger portion of the number, and again, an increase in length of stay. Now, this article and this survey really gives rise to the understanding that appropriate staffing levels actually saves facilities over time more money and improves our patient outcomes. And there have been many studies. This is one of the most recent ones that's been performed, and it's a beautiful study looking at these 87 hospitals, about 1,400 nurses being surveyed. The other thing to remind ourselves, as I mentioned before, is that when you have a poor staffing ratio, it leads to nurse turnover rates. Now, none of us are surprised by that. We've all come through the most horrible thing that I can imagine. I've been around since 1976. This was the hardest 2 years of my career, and I know of yours. Even if you're a younger nurse or a more experienced nurse, this has been the hardest 2 years. We are not surprised to see that safe staffing was incredibly important in terms of looking at nurses feeling overworked, and by really affecting retention and recruitment. And how nurses actually are feeling burned out. Now, burned out is a little bit of a PC term. I don't feel like it's always well defined, but I think now what we say is we're emotionally, physically, mentally exhausted. And coming through this last 2 years, many of us felt a lot of certainty about the value in which we were employing on individual patients, but overall having some question about how we were valued within our institutions. And again, we bring that back to safe staff nursing ratios and the kind of support that we receive in providing care for our patients at the bedside and how incredibly important that is. So I want to pull from some of these surveys. This is the NYNSA. This is a nursing association publication in New York that looked at surveys of over 4,000 nurses and just discussed that in that original survey, looking at how new hires and also more experienced people were perceiving their profession and what was going to occur over the next 5 years in terms of turnover by years of tenure, by new nurses coming into the field and then leaving the field because they may not actually feel that they have incredible value. So if you look at this, 31% of nurses leave the nursing profession or leave their position of employment within 1 year. The median nurse tenure fell in 2021, 19.5%. And the average tenure is 2.78 years. I have been at Grady since 2011. That's only 11 years. And I have more years than that as a nurse. I started as a nurse in 1976. People are like, wow, you've been there such a long time. It's like a blink of an eye. 11 years doesn't seem that long. But in relationship to the environment in which we work, that is really seen as significant nursing tenure. So we really want to think about how we're actually embracing new individuals and new hires, how we're bringing them on board, and how we are actually using technology to help support their daily practice. Now, I'm going to remind you that probably the most common technology that we talk about is our electronic medical record. I think most of us would say EMR is beneficial because I do point and click, and I click off all the things that the JCAH wants and that my hospital leadership wants, but I spend an inordinate amount of time in documentation and much less time in the actual act of caring. And I think most of us would desire more time with patient and less time with documentation. So we have to really think about how is technology going to evolve in order to assist us with less time in documentation, smarter alarms, more support, and providing us with more capable time at the bedside. And that really is the goal. That's the goal of technology, not just to meet criteria of the JCAH, not just to meet criteria of the hospital leadership, but to actually assist us in providing more time at the bedside. So if you just take a look at this beautiful evaluation, you can see that the numbers are really significantly concerning. We look at nurse turnover rate pre-pandemic and intra-pandemic. Not a big surprise that we saw a significant nurse turnover rate during the pandemic, and not a big surprise to see that from 21 to 2022 that you're seeing a significant rise in nurse vacancy. And we're thinking about how are we going to get nurses to fulfill this? Where are we going to get that? Where are those nurses coming from? How do we assure that we are generating an environment that embraces a whole significant generational evolution in technology and to utilize that technology to assist us to provide better care for our patients without ever replacing our human caring capabilities. And that really is the most important concept when we think about how to use technology to ease our burdens. Now, I again want to reiterate that poor staffing ratios lead to excess spending. Now, that's really, really important. After ratios were implemented by law in California, safe staffing ratios, hospital income rose from 12.5 billion, almost double, to 20.6 billion. This was amazing that actually by implementing staffing ratios, requiring that they had a large staffing pool, and really providing one-to-one and never more than 1-to-2 care in the ICU, and never more than 1-to-4 to 1-to-5 care on the medical surgical unit, that actually saved the hospital money over time. Now, you've heard, maybe your grandmother, like somebody like me, who says, don't be penny wise and pound foolish. That's what this is. Penny wise by reducing the single most important cost to the hospital, which is the nurse. If we reduce our nursing and we aren't supporting our bedside nurses, then we significantly and profoundly impact the profit of our hospital. And no matter what our hospital's missions are, they all have to make a profit in order to keep going. So we really think about how can we work together with our leaderships and with technology to actually help to staff appropriately and to unload some of the burdens that are on nurses today that are not actually about direct caring. And I think that is really important, that we really have to think about those burdens and how those burdens impact our stress level, create depression and anxiety, and the feeling oftentimes of a job not well done, even though we're doing the best we can. Because within the acuity and the level of requirements within our institutions, as human beings, we are often not capable to be able to integrate this huge amount of data and input of information that actually assists us to provide the best possible care for our patients. So that's a really important aspect in terms of how we evaluate. And that's really what's given rise to what we call moral distress and moral injury. And everyone talks about it. Again, it's a word that's bandied about. A lot of people use it. It is really important, though, for us to understand that. Moral distress means I go to work knowing that I want to do a good thing today, the very best I can. I know what's right to do, but because of policies and because of acuity and because of my staffing ratio, I am not able to do it. That's really what moral distress is. I can't do what I know is right because of things that are generally outside of my control. Moral injury is this repeated distress over and over and over again. So I've been working 4 years on my ward, and on my ward, it used to be 1-to-4, 1-to-5. Patients were moderately acute, but most of them were progressing towards discharge. And then fast forward to today, I'm taking 6 patients. Sometimes I'm taking 7. Sometimes I'm in charge and I've got 4 or 5 patients. My patient's acuity level has significantly increased, and I don't feel capable of providing the best care because of these limitations, because of the data that is flowing from my patients and how acute they are, and my human limitation for processing this information in a very high acuity and high demand situation. So I have to consider all of this when I'm thinking about what it is that I'm trying to do. So what's that problem? And there's a lot. We know there's a lot of issues that impact the way in which we give care today. Again, nobody enters into this field as a physician, a pharmacist, a tech, a nurse without a desire to do right and to do good. And we know that's what we're desiring, but we really think about the fact that we may have a lack of administrative support, that we feel, it may not be true, that our leadership doesn't really understand what it is that we're undergoing every single day. All the data that is flowing through us and all of the decision making that we need to do at the same time that we need to point, click, file, point, click, and file. And that there's some reluctance sometimes because we're looking at a storyboard of staffing without actually evaluating the acuity of staffing and the amount of data that we are contending with, and really not always making sure that we have appropriate staff. Now, this is not intentional. It is just the dissonance that occurs from the people who are providing care to the individuals who may be making financial decisions. Now, when we look at what the US Bureau of Labor Statistics say in 2021, very, very important to really appreciate that about 276,000 additional nurses will be needed from 2020 to 2030 to actually achieve the same staffing ratio that we are working with now. Now, it's a great time to consider going to nursing school because this, of course, as we know, you will always have a job. And this is growing. The growth potential for nurses is very rapid. The educational availability for nurses is also very rapid. It's a great time to become a nurse and to really do something meaningful. But from that same survey, the NYSNA survey, you can see that if we're looking at supply and demand, looking at 2030 supply and 2030 demand, you can see that all the way down to, and this is not every state, this is just representative, till you get to Montana, North Dakota, and New Hampshire, you can see that every single state is going to be working at a significant deficit. So, by the way, my friends, the time is now for us to consider what is it that we can do to actually support us technologically, to support our environment, to improve our alarm capabilities and the evaluation of our patients. Because yes, indeed, these staffing ratios significantly, profoundly affect our patients. And of course, that's what we're all about, right? When we look at shifts that are below staffing levels, there's a 6% higher risk of death per stay. If we have an appropriate average year of experience, so 2 years, 5 years, 8 years, 10 years, thinking about tenure, which has been significantly reduced in the staffing shortage, 4 to 6 fewer deaths for each additional average year of nurse experience on your area. That means we need to recruit and retain experienced nurses, not just new nurses. And for every patient above the 1-to-4 nurse patient ratio, there's an increased likelihood of patient death, 7%. These are horrifying to me. So I want to think about ways that can enhance my caring, my evaluation, my interaction, my eyes on that patient, and thinking about ways in which I can do that. And by the way, it isn't just me. The WHO in 2022 published the top reasons that can help relieve some of our burdens. And you should really look at that WHO 2022 report. But what I want to focus on is number 3, which is to expand the use of digital tools that support the workforce. By the way, not replace, support. So whatever we actually engage with technologically, that is not meant to reduce staffing ratios. I have to be sure I'm involved with my hospital leadership on committees to make sure that we appreciate that technology and the digital tools available with technology are not being used to reduce staff, but to enhance them. And the reason is, as we can all appreciate, if you've been alive long enough to have been around before email, before internet, when you used to have to turn through pages of maps or go through files of thousands of papers, and now with a simple click, you can actually look at a patient you took care of 2 years ago and their file, as long as you have their MRN. It is really important to remember that the major effort of technology is to reduce your time spent on tedious jobs and evaluation of large pools of data. Now, that's the beginning of technology. That is not where technology is going to end. We really know that technology is going to continue to grow and enhance our care. But by the way, I don't think it's anyone's intention to replace the human aspect of caring. I think that's the thing that we carry with us that technology, even robotic technology, is not going to be able to replace. But what technology does allow us to do is actually evaluate these large pools of data and make predictive perspectives, predictive algorithms that tell us about patients at risk for decompensation. I want to make sure that we appreciate what's known as human factor science. So when we talk about human factor science, it's focused on really trying to optimize the human performance. And that human performance is about the behavior of individuals, but utilizing technology helps us to minimize our human frailties. No matter how big your brain is, no matter how young you are, no matter how old you are, you do not have the capability to process these extraordinary amounts of data and to actually design algorithms that are changing day by day with more and more data. We don't really have the capability to go to the bedside. We can use modified early warning score, we can use a modification of a modified early warning score, but we don't really have that capability on a patient-to-patient process to analyze their data and make a prediction with thousands, millions of points of data and say, there's been 400,000 patients who presented in this way, and we know that in 15 minutes they will become hypotensive. We don't have that capability. What we do have is the capability to create technology that facilitates this for us. So I really appreciate this WHO list of how to relieve the burden of unsafe staffing in 2022 and looking at that process and how to move forward utilizing digital tools to enhance our workforce. So very, very important to appreciate this concept of digital health. This is the intersection of technology and human caring in healthcare. It's utilizing this total digital transformation and doing it transparently with the use of software and hardware and services. And this actually can facilitate and improve our patient outcomes because it increases efficiency of the healthcare operations. So smart alarms that are negotiated and narrowed to actually tell you about a patient at risk, to actually give you alarms that are actionable and not just bothersome, to actually improve the journey for the patient and to actually reduce human error, which I think is so significant and really profound. And all of us know that as we become more and more and more overburdened, we are more and more and more likely to have human error in the caring of our patients. And we are, after all human. So really important when we're looking at that technology is to recognize how it's going to help us relieve some of this burden. So a nurse should be at every patient's bedside, watching, observing, caring for that patient continuously and interacting with patients, learning about the patients, learning about their family, and actually providing critical thought analysis to the data that's been gathered. The reality of our work environment today is we're so frenetic. We're just running around trying to get all our tasks done and dealing with all sorts of administrative demands, particularly point, click, file, point, click, file. Most nurses today will say 60% of their day is spent charting on the computer. So really, really important. We really need to change that so we can improve our nursing time with patients. Too much time is spent in activities other than actual patient care. And the whole idea of utilizing technology is to get us back to caring and reducing the time that we spend in activities that are not about patient care. In my practice, a lot of time for nurses that I work with is spent in hunting and gathering, looking for supplies, documenting, coordinating care, administering medications, things that are really important, but so much time spent in hunting and gathering, so little time now is spent in actual caring. And I think most nurses would tell you that that's the truth in the way in which they are operating at the bedside. So again, think about how technology can relieve some of this burden, because much, not administering medications necessarily, but much of what we do is administrative and is finding the right person to notify and spending time organizing the supplies. And again, the point click file of so much of the time that we spend at our bedsides today. So I really want to think about technology and how to utilize that appropriately. So I want to just talk very quickly about machine learning and the understanding of algorithms and the development of algorithms that actually utilize significant and profound processes of information. So machine learning algorithms process unimaginable billions of amounts or data points in information in the blink of an eye, in the blink of an eye, with more precision and much more rapidly than human beings can, looking at even the smallest details and correlating that information, comparing it to every piece of information that came before and integrating every piece of information that comes after. It's mind-boggling to me, mind-boggling. But I also want to remind you, I began as a nurse when you did a 12-lead EKG, you were using suction cups and you could only do one chest lead at a time because you had one brown suction cup that you put on and moved across the chest. Think about where we are now with EKGs and with our 12-lead EKG process, and think about where we can be in the transformation of technology, creating safe, reliable systems that help to manage flow of information in extraordinary ways that us, people at the bedside, have not even imagined could happen to improve our care and provide a safe environment. Now, a lot of times people talk about there's many things to discuss. I'm only focusing really on machine learning and algorithms, but a lot of times we refer to this as AI. And actually, it's not artificial intelligence, it's augmenting our intelligence. I think it's important to change that terminology so we don't see this as some alien thing that's come upon us. It's augmenting our intelligence. It's a powerful tool and partner because it can help us to evaluate that data, make precision-based decisions, to understand through those point of data what types of interventions we need to apply. And then we can evaluate how the patient responded. And again, we can use technology in that way. This can help us to optimize safety and optimize performance. It's incredible the way in which this can move forward. So I just want to remind you about machine learning, how different it is from the traditional approach, that we're using this data to create a model, and not in a simplistic way, but using thousands and thousands, millions of points of light to tell us about how to predict what's going to occur for patients, how to generate smart alarms that are actionable, how to control alarms that are not actionable, and how to give us a process to improve our bedside care. How incredibly and profoundly important that is. Machine learning leads to smarter alarms. That will help us to decrease our alarm fatigue. Using that smart alarm technology increases the number of actionable alarms. Now, let's be sure we understand what I've just said. I talk a lot about alarms. I've been on the task force for the Society of Critical Care Medicine about alarm and alert fatigue. We've had multiple publications, a lot of presentations, but I never want to obliterate actionable alarms. Actionable alarms mean an alarm that makes you aware of an issue and provides you with that information. And when you act, that alarm goes away. And I'm going to show you an example of that in just a moment. This is a really important aspect. I don't want any more nuisance alarms, but I do want actionable alarms. So when we look at machine-based learning and machine learning algorithms using this information, using all the parameters of the patient, integrating the laboratory data and the process of the patient, the position in the bed, and points of information we're not even thinking about at this time, and how that actually provides this medical data mining that allows us and facilitates our capability to predict what's going to occur to that patient physiologically. Now, obviously, it doesn't predict their emotionality and it doesn't really predict their mental status, but it does predict utilizing parameters like end tidal CO2 and blood pressure and heart rate and respiratory rate and pulse ox and correlating labs into that. So again, beyond Muse, beyond modified Muse, really looking at the integration of data to give us a platform where we could come in at the beginning of our shift, and based on these algorithms, we can look at the patients who are at the highest risk and then patients who are at lower risk. And of course, that can change at any time during the day. But in the beginning of our shift, knowing how we should be arranging our staffing to provide better care for patients at a higher risk, making sure that the appropriate trained staff is caring for that patient, that the appropriate folks have been notified about this patient's potential for deterioration, and by intervening early for patients before they are in crash situations, using machine learning to guide us in this opportunity for the future is an incredible opportunity for us in healthcare. And by the way, we need to be at the table. We as nurses need to be at the table. Old ways won't open new doors. When we think about automation and machine learning, handling all those standard repetitive tasks that take time away from the bedside, I don't want to do repetitive tasks and data mining. I don't want to do that. Who wants to do that? And do I actually look at all my information, making the search for it easier, putting relevant information at the top and less relevant information down? We generally are not doing that because we just don't have the time. We may not have the capability. And then reminding ourselves about rapid processing and categorization, which really helps us to look at patients at risk, to prioritize their care, to prioritize our staffing, to be able to move fluidly between high and low density and high and low acuity in our staffing ratios. Incredible opportunity. By the way, machine learning, certainly as it exists today and over the next 5 to 10 years, no threat to human caring. I don't think it will ever be a threat to human caring, but I think we have to be cautious how we build these aspects within our healthcare environment. And we need to be sure that we have bedside nurses who are knowledgeable at the table, making these decisions, contributing information to vendors who are developing these technologies so that we assure that human caring will continue to be human caring. But we cannot make a strong predictive model. We've attempted that. We've attempted that with Muse, with modified Muse, with News, with our sepsis protocols, and yet we cannot capture all of our patients because we are not able to process all that data. And also, we have patients who have anomalous changes that maybe happen once out of every 5,000, which means that that's not really significant in terms of how we're evaluating our patients. So we're going to think about these machine-based algorithms helping us to provide necessary guidance and information and moving us forward in our practice in today's environment. Really, really important in terms of how we're going to move forward. So I'm waiting for my slide. So what's next for us? What's really next for us is to move from systems of records to systems of intelligence and augmented intelligence. Everything that I've talked about, smarter search algorithms, predictive software, predictive analytics, uh, capabilities that actually many of which we cannot even consider at this moment in time because we don't have the full breadth and depth of where technology is going to go. Each process brings us 5 steps forward. So we continue to move forward in our process towards the future. Be prepared. So when you look at this survey from McKinsey and Company, it talks about what's going to happen over the next 5 to 10 years in terms of synchronous telemedicine. Telemedicine is burgeoning and it's going to continue to grow. That's a great way to support us, and it's very, very helpful. Really, really important. Okay. The asynchronous telemedicine, very, very important. That helps us to move forward as well. And that's going to grow at leaps and bounds, almost doubling in the next 10 years. How that's going to engage our patient, give us remote monitoring, staff support, all of this is incredibly and profoundly important. So as we move forward into our future, these are going to be really important perspectives of how we move. We face a lot of cultural challenges because technology can be frightening. We're worried about replacement. We're not sure what augmented intelligence is going to enable us to do, what it won't be able to do, and how that might take the place of staff. Let's be sure that we don't let that happen. And that is not the goal of augmented intelligence and technology. It is to support us in our future as we have a shortage of trained workforce. And I want to share with you a couple of real-time examples from today's practice. So really, really important as we move forward. Okay, so I think I moved forward one slide too quickly, but it's okay. I'm going to talk about algorithmic glucose and insulin management, something I have a lot of experience with. I'm the glycemic management point person at Grady Health System. And in 2016, we had a hypoglycemic incidence of 37% of patients who were receiving continuous IV insulin at Grady Hospital. So in 2016, we moved forward to an e-glycemic management system from our paper protocol for all ICUs. And in 2018, for all monitored step-down beds, we transitioned all of those patients with an attempt to get patients to a target blood glucose 140 to 180 and to prevent hypoglycemic events, which would be considered a glucose less than 80. And that was our barrier. So I want to just share with you just very quickly that whole perspective. So you're going to see this right here in October of 2022. This is the downloaded information that I've had since 2016. Almost 5,000 patients on continuous IV insulin. 186,823 blood glucoses performed by bedside nurses and patient care techs. And what I want you to see here is hypoglycemia of less than 70% was hypoglycemia of less than 70 milligrams per deciliter, less than 35%, 0.35, 0.35. So from 37 to 0.35%. That was because we integrated technology that we worked with together with our staff to actually utilize technology and to assist us in moving forward. So I want to just show you this in a very nice graphic is that the highest level of hypoglycemia less than 80 and less than 40, 0.01%. That's not 1%, that's 0.01%. This was one of the ways that we utilized technology to move us forward. So also not just this. In 2021, in our emergency department, where we see upwards of 350 patients per day, greater than 160,000 visits per year, we implemented glycemic control in this process as well. And it's a team process. It's IT, it's the vendor, it's physicians, pharmacy, nurses, techs. Fantastic. Moving forward, I want to share with you that beautiful, incredible data. So this is basically what we see as the bedside nurse on our computer on wheels. This is what we see at the bedside. It tells us our patient's blood sugar, what the range is, what their insulin is, and this factor, which is called a multiplier, which is utilized in directing the rate of insulin. It uses this multiplier to factor out the insulin, and that depends on the patient's height, weight, their BMI, and also if we have a known hemoglobin A1C. All things that we don't think about when we're doing a paper protocol. And it gives us this incredible agenda of information as we're evaluating our patients, really helping us to move forward. And you can see here, this is all information for our patients and looking at our patients' glycemic control and how that occurs. This is a way that we have deployed technology in our institution. It's moved us far forward. But this isn't the only thing that happened. We actually then removed to remote glucose monitoring devices during COVID-19 so that we actually had an integration of continuous glucose monitoring so that it wasn't necessary for us to enter the room. We could do continuous glucose monitoring and then adjust our insulin based on what our e-glycemic management system was. So from 2016 to 2021, we evolved from a paper protocol to electronic glycemic management to the integration of a continuous glucose monitoring device, only in tests, not used everywhere. But it changed our practice significantly, and it continues to change our practice and to improve outcomes for patients. But not only that, we're also thinking about just in the literature, looking at this is about patients in the operating room who are post anesthesia induction hypotension. And typically, where you see that little red ball, this is where intervention occurs, but the patient is already hypotensive. Predictive algorithms based on all those points of data will actually have you intervene here before the patient ever becomes hypotensive. And we see this iteration in many devices that are available today. We're just taking a look at this one device. I'm not speaking for any device, but this is something called the Acumen device. It's a hypotension prediction index, and it actually utilizing calculation and machine learning gives predictive algorithms about what's going to occur for your patient and to your patient significantly before it does, and gives advice, not in order, advice about whether you need volume, inotrope, or vasopressor. Much of this is derived in very high frequency. This brings into focus subtle changes that may not be valuable by the human eye. These are the things that move us forward. This is what's moving us forward to the future. This is where technology is going to help us. No threats to human caring. Machine learning does get to similar results that humans will, but much faster, because it was made to deal with large data sets. And especially in process information tasks, machine-based learning algorithms can actually profoundly and significantly support us as we move forward to try to improve outcomes and to actually be able to predict about patients that are going to deteriorate, to give nurses more time to be at the bedside, to save our institutions money that can support more nurses' salaries, to reduce inequities, to reduce pure subjectivity, to quickly predict who's at risk, to equalize healthcare across all surfaces, across all ethnicity, all race, all religion, because it's technology. It's not human. And what it's going to allow us to do is increase the time we have for human caring at the bedside. I'm so grateful that you've come here today. We have a short period of time left, so I'm going to turn now over to my colleagues, first Monica and then Lauren. And I just want to say thank you for everything you do every day and for doing the best you can for our patients. And I'm so grateful to be in this profession with all of you. Thank you so much.
Thank you, Barbara.
The poll.
Thank you. We do have one more poll that is going to show on the right-hand side of your screen. Just as a follow-up, it is just like the first question. We would love for you to go ahead and please go ahead and share your answers, and we appreciate your feedback. Again, can technology impact my patient and supplement my care but not replace me? And I will turn it back to Lauren and Barbara. Thank you.
Thank you so much, Barbara. As always, a wonderful and thought-provoking presentation. For everyone who's looking for their CEs, this educational activity is approved for one contact hour for nurses and respiratory therapists. To obtain your CE credits, go to www.saxtesting.com/CO. You'll need to register at the site and complete evaluation, after which you can print your certificate. Thank you again to Philip for providing support for this educational activity. Finally, the archive on-demand version will be available at betteroutcomes.org, and an email will be sent to all registrants once it's available. The on-demand version will be accredited for nurses and respiratory therapists as well. And I think that about wraps us up for today. Monica?
Thank you. Thank you so much. Let's go ahead and wrap this up. I want to thank you all. And immediately upon conclusion of this webinar, you will be presented with an online survey. So please keep your web browser open, and we do appreciate your feedback. Once again, to obtain your CE credits, please go to www.saxtesting, which is SAXE testing.com/BO, and please register at the site and complete the evaluation. So this does conclude our webinar. This concludes our webinar for today. And we thank you on behalf of our presenters and Sachs Healthcare Communications and our sponsor, Philips. We hope you enjoy the rest of your day.